My story began with a death sentence.
My beginning is before AIDS.
She talked about this new disease. It was going to change the face of medicine in South Africa.
Very few of us had any understanding of the epidemic.
Really, I had absolute, complete faith in the fact that, science would prevail.
When the epidemic first came, I thought it really didn't concern us. It was a problem of white gay males in California, and that was a dreadful mistake because, as you've seen, from the 80s, we've become the worst affected country in the entire world.
We had HIV. We didn't have the drugs at that stage.
The drugs haven't arrived.
Who could afford to be on the antiretrovirals? And you were talking about $10,000 a year.
Yeah.
We had this real view that there was new hope. I think we were all a bit patient. We were saying, Mbeki comes to power and we need to allow him a bit of time to bed down. Same was true for Mantu.
What I kept hearing was, you wanted a policy on treatment, you've got it.
Some of the memories I have is of a lot of people dying, a lot of friends dying, personal confrontations that I had which were unpleasant with the former Minister of Health.
It was already known that the infection in children can be prevented, and yet they were still dragging off feet.
There was a bit of conflation of the issues. We then got into a bit of a debate which polarized us as a country.
As we grew, AIDS denialism hardened. As it hardened, we had to fight it harder. As we fought it harder, Thabo Mbeki, being a proud and arrogant man, hardened his position further, and unfortunately we got into a kind of, I think, vicious spiral.
There were very few people who supported us fighting Thabo Mbeki. And within the government itself, if there is a handful I can think of who stood up, it's a lot.
From an international perspective, we were embarrassed.
Bearing in mind that it's always been the case that an effective response will have to be a national response.
What moved and inspired and motivated you in those days was the personal interactions with people.
I think it's right to capture this history.
I personally worked with the World Health Organization for a number of years before coming to work for Catholic Relief Services in South Africa. So I was working in Papua New Guinea at the time, and these were in the, I was in Papua New Guinea in the 90s, and that was when the epidemic started. So then I came to South Africa and was working with Catholic Relief Services here, which is an international NGO. It's actually the official development and relief agency of the United States Catholic community. So they work here in partnership with other organizations. In this case, our work was with the Southern African Catholic Bishops' Conference. My impression was, a country with great inequalities, a country that was, being, after liberation, got given a double blow of the HIV epidemic, and was suffering under that and not really able to respond very well, or not doing it. But what I found after being here for a while was that the churches had been responding in the best way they could. And I think the history of all this happened goes back to the 1800s when when religious communities came out and provided needed services for people in places that I call where no one knows and no one cares, out in those communities, and started hospitals. And by the 1970s, there were many hospitals, maybe 50 hospitals, I don't have the exact number, in what were the homelands at that time. And then the government took those over for their own reasons. And the people started working more in primary care in the community and picked up the slack there. So and they were providing home-based care and orphan care and many, just whatever was needed, filling the gaps for health care and palliative care and just social services. So, so then when treatment became available, when people could, save lives with antiretroviral drugs, there was this network out there that was ready to respond. What I encountered were many ordinary people out in communities where there were very few services, doing what they could for their neighbors, out of their heart, out of their faith, out of their, ideology, out of political commitment, whatever. Were doing, helping their neighbors in little ways. People were dying, children were being orphaned. They would bring food, they would wash patients, they would try and transport them, doing what they could with no money. There were no resources there for that. Meanwhile, so this was the day-to-day reality in many communities. We, as a funding agency, helped as we could. But in those communities, people, they didn't have computers, they couldn't write proposals, they didn't have electricity. There was no way that they could, fit into the usual funding kinds of streams. Yeah.
Resources is the jargon.
Yeah. But meanwhile, the Catholic Church had an AIDS office. And because there were all these 100 projects all over the place that through the churches and the parishes were trying to be of support as these cases kept coming and people were sick, and what do you do for them? And so then they decided they needed to have some kind of a coordinating body so that they could give the caregivers some training, and so that the quality of whatever service was being offered out there would be improved, and so they could look for resources. So that office had been established. This AIDS office had been established in '99, and when Catholic Relief Services was providing funding, we were able to provide funding directly to the AIDS office to fund these programs. Many of very little money. I mean, a few $1,000s here or there, but it made all the difference. And so that's how those programs started. Then, when PEPFAR came, you could Catholic Relief Services applied for the PEPFAR grant, and in 2004 they received it for 9 countries, including South Africa, and it was a grant for antiretroviral treatment. And then those little places could not only do palliative care and take care of the dying, but they could keep people alive so that they could raise their children, stay working. It was interesting because in the early days of these programs, as we were looking at it, we were thinking, about the issue of stigma, and we start offering these programs, and people wouldn't come because they'd be worried about their, neighbors knowing. But I'm thinking of one place, just particularly in Bronkersbreed, the Sizanani area, the St. Joseph's Care Center. Okay, yes, I do. So it's a whole community, and now they have orphan care, and they do everything there. But when at that time we weren't funding to do testing, so people would test, and then they would bring their results and come, and they would be evaluated for treatment. So again, worried that you open the door and start this and no one will come, because they would be concerned on the stigma thing. The day the door opened, people were all over the place, and people came. They knew because that center, like so many others, had been in the community forever. People knew and trusted those places. It wasn't like going in and starting a project. I'm coming to a community and I'm starting a project, and we're going to provide treatment, and we're going to do this and that. No, they were there. They've been there, and the relationship was there, and they were part of the community. So you didn't have to do community mobilization or all those kinds of things. It was just there. It was already there. So people came. It was also interesting that some of the people that we worked with, some of the, dare I say, international consultants that gave us advice, were very concerned about, there had to be back doors that people come in, and all this, ways people could slip out. But what we found in those centers were people they all gathered together and talked to each other and supported each other. And to me, that spoke volumes about, what had been created over many, many years in terms of trust and working together. It was a safe place, and and continues to be a safe place. And so there are places like that all over. I think in terms of impressions, some of these treatment sites, as we call them, who are working in these communities, are no more, than a freight container, or that people come to, or one of them, is sort of an old station wagon, to use that term in South Africa, station wagon. Yes. Yeah, that old stuff. And with different, with files in the back, and then, the nurse will go out, and there'll be a health worker in a shack, community health worker in a shack, and she'll have lined up the patients, and the nurse sees the patients and goes on to the next place. So lots of efforts to keep things simple, use the funds to not do anything fancy. I always say nothing fancy, just provide the best care that's possible to the most people. So you see, also what you see is a lot of overworked people. The needs are great, and the staff is always a little bit, put upon, I'd say. Yeah.
You see, there were other places like Sizanani.
Oh yeah.
Tell me
Yeah.
about some of them.
I think if you go up to the Rustenburg area, you come to a place called Tapaloko. And Tapaloko, how can I describe it? It's many things. It's with the Bishop Dowling of the Diocese of Rustenburg, who is very committed to providing services for people living with HIV. And on the diocese property, right next door to his house, they've built a hospice. And the idea being that people, who were in the shacks and in very difficult circumstances could come and die with people caring for them and in dignity. But of course now, then treatment came, and people could live. And so there's a large treatment program there, and that's where the nurse goes out to all these different sites and provides care. There's also Freedom Park. I don't know if you've ever seen Freedom Park in that area, and it's these communities are around the mines. And in the old days where the mine workers were in hostels and away from their families, women would gather around, and different people would just gather around those mined areas and shacks. And they had, there's no water, no electricity, no surfaces whatsoever. And so this site they've put up some freight containers and provide primary care there for people in those communities. So yeah, so that's sort of the urban side. In the more rural, I guess you won't call it urban, but anyway, it's very it's a dense area of population. Moving out into the rural areas where you have, you have farm workers, and going out to, the health workers go out to the farms to provide treatment for them. And in some areas where there's, in KZN, where the AIDS office has managed to get funds to actually build some houses for orphans that are, living on their own. So it's very multi thing. But another place to go would be the Winterfeld, where the Sisters of Mercy have been working. Have you been there? I would recommend you go. I was in South Africa in the 80s, I guess it was, in the 80s. And I don't know if you know the Winterfeld area. It was sort of a dumping ground in the old apartheid days. People that didn't fit into one population group or another, or foreigners, sort of ended up there. It wasn't South Africa, and it wasn't Bophuthatswana. It was just that in-between area. Yeah, very much a no man's land. And so people just came, but from the different areas and countries, and there was no real sense of community in the sense you find in other places. But it was it's dry, there's no water, it's a very, the land is very difficult to grow anything on. But the Sisters of Mercy started out there with a clinic, and put in a freight container. These freight containers are wonderful. Everything starts in a freight container. And then, over the years, they've built that place into, it's an oasis. You drive through all the brush and the shacks and the really desolate area, and you come to this oasis where they've got boreholes, and they have, they can grow vegetables there with the water. And the people that don't have grants and are very poor, they give them a plot, and they grow their vegetables on that, and that's theirs. And they have a dental clinic, they have nutrition counseling, they take care of TB patients, they have an orphan program, it's just whatever you need, it's there. And so it's also, and when you walk through there, you ask what you see. And I was just there recently. And I think what I felt so good about are these lovely grounds in the middle of all this desolation and poverty. But they also have a school. They teach people past for matric, adult education. They have a sewing group. They have all kinds of income generation. They teach people to be welders and carpenters, all that, and how people in the community were so comfortable there. That was the thing that struck me the most. Watching through in groups of 2 and 3, like it was theirs, and it was really I had a good feeling about that. So, yeah, term chronic illness. Well, it certainly changed. I mean, in terms of, we had very many. Bishop Dallin can tell many heartrending stories of the children that were left behind, of the children that were, sick. And now, for us, I think it meant that, people could raising their children was a huge thing. And, life's changed at this point. There's one little boy, and, just the whole dynamic of what we could do as we worked with them, prayed with them, walked, sort of accompanied them on this journey of whatever of life. We have one little boy who actually was the one that helped his parents take the antiretrovirals. And so that community thing, it was, I don't know how to describe it very well, but, and that's, we felt, we have to do this. I remember a debate at one time, and maybe it was in all of our minds, about what if the money for antiretrovirals ends? The church is not going to have this money. What do we do? Is it right to put people on when we don't know how long we can keep this up? Who knows? What the future will hold. And that at those days, it looked pretty grim. There was not, in terms of the public commitment to provide treatment. And the churches certainly don't have the money, and we're very grateful to get the PEPFAR money to buy those drugs. But, you could just tell, no external money is going to last forever for life-saving, for drugs that have to be given the rest of somebody's life. It's just not going to happen. So what to do? Is it ethical to start people on when you don't know? And I remember one church leader saying that, if I can help someone have 2 more years of life to keep, their child is 2 more years old and they have that's what we have to do. So that was the decision to move on. When we got the grant, we made an agreement. We signed an agreement between U.S. government, us, and South African government at the time, that we would follow government protocols, we would use government, we would do everything according to government protocols, and we were happy to do that. But the issue, I think, in terms of working on the ground, was that, dare I say this, in the old days, for the church, the government was, the enemy, so to speak. And so you just closed yourself off and did what you could and hoped nobody interfered with the area you were working in and all that. Now, recalling that the church has been there for many years. So they've gone through all the changes. So now that had to change. And so the message was that we, communicated was that this is a new day. We're here to support the government's rollout of antiretroviral drugs. Now, they had a strategic plan, a very good plan, and there may have been, all these barriers and conflicts and about it in government, but it was there, and our job was not to compete with government, but we were here to support the government's rollout. And to communicate that to our treatment sites and to government was our thing. But I think we have always felt that, you know, in South Africa, as in many countries, health is the work of the state, isn't it? It's the responsibility of the state. And our job as church is primarily to fill the gaps where those services, where the state can't offer or won't offer those services in certain communities. And when government can take over, then the church can move to, you know, other areas of work or geography, or, you know, and look at those gaps. In other words, with the exception of a few comprehensive primary care hospitals and tertiary primary care centers and you know, secondary level hospitals, yeah, most of that would be the role of the government. So it was really important that we work with government and that they, yeah, we get to know government people and work with the nurse in the nearby clinic if we could, and work. I think it depended on the place, and but I think we got started on the right foot in that in every province that we as started treatment in every province, we got the agreement of the provincial authorities to do that. And so, and we communicated with them as much as possible. We shared our statistics and what we were doing with them. And so that over the years, I mean, it's been 9 years now, over these years, we've developed some very, you know, collaborative relationships, and that's what we wanted. And now, as funding is decreasing, we have different partnerships with government in some of these places, these outlying places, where government is providing the drugs now for these clinics, and our services are being connected to government services as a down referral or something else. So, yeah, the intention always was to work together. And the church, certainly through various organizations. The AIDS office was represented on this, you know, SANIC, and as on the religious, as a religious sector. We had people from the Treatment Action Campaign working with us, and some of the staff went to those meetings. And yeah, we also, from the, there is something called, within the Catholic Church, called the Catholic Parliamentary Liaison Office. And that's based in Cape Town. I don't know if you've heard of it. But that office does research and advocacy with parliamentarians on different issues, and certainly HIV was one of those issues. But what we decided early on was that we would use there's me, I'm from the U.S., and there's, you know, one other person in our office, but that in this activity, we would work as a team with our South African counterparts, and really work as a team, and, you know, make joint decisions. And I didn't always like the decisions, and you go with it anyway. And that we would use all South African all the South African experts, all the experts we needed were here in South Africa, and we would, and they would be our consultants and our experts, and we did just fine. So, yeah, we had really bad experiences in the beginning. One of the things we had, maybe I can tell this story. One of the things we had bad experiences with were all the computer people around, the IT people, the companies that wanted to get in on the deal. And it's, you know, it was always with a touch of the button, you'll have all the data you need to give to, you know, the U.S. government, the South African government, all the monitoring and evaluation. And we made some, in the early years, yeah, we bought into that, and it was disastrous. You know, it took up the time of people, you know. I think there were a lot of people also in the early days that wanted to use our sites as pilot. You know, we'll pilot so-and-so. Well, our sites don't have a lot of money, and they don't have a lot of staff, and we're not really interested in doing any exotic new thing, just taking care of patients. And, you know, to have people involved with things that took a lot of time and, you know, and their energy, and it was just, yeah, those kinds of things we had bad experiences with and decided never to do again. The priority has to be taking care of the people in the community, and there are many interesting things to do, but you know, if that takes away from saving lives, then it's not worth it. Well, I mean, before HIV came along, foreign governments weren't putting money into South Africa because of, you know, the political situation and all that. And it was only, I think, well, I wasn't here at the time, so I don't know, but I would assume that it was after '94 that things, that international aid became significant, and then with the HIV, it did. But yes, it's been quite a journey. Yes, I'd like to tell them that probably one of the sad reasons that people disappeared related to how it's been forever, you know. I mean, first of all, people from poor communities haven't received, you know, good care from any of the governments. The new government is trying, but that there has been a huge need, and so people with not just HIV, but, you know, dying in childbirth and dying of you know, the usual childhood illnesses. This has gone on for years. So with HIV, somehow the idea, even with the new government, was HIV was associated with shame, I think. This is what I think, you know. And that to say that, you know, people of color were, you know, massively infected with this sexually transmitted illness was to speak badly of them and speak badly of their culture and their behaviors. And I think that was part of the great barrier for the government stepping up and recognizing the need and providing the services.